We all know that detection of regional wall motion abnormality is integral to the evaluation of LV function, and analysis of RWMA is characterized by considerable inter-observer variability even using high quality imaging modalities. So what is regional wall motion abnormality? So here we look at basically the endocardial motion and also the systolic thickening. So when we look at these images, you can see the endocardial motion is happening and also the LV is thickening. So we have to look at these two specific parameters when that is what we mean by telling regional wall motion. But regional wall motion is influenced by regional flow, which again is responsible for the regional thickening, and it is also influenced by tethering or the hyperkinetic effect, the cardiac translation and rotation during systole, cardiac motion during respiration, and various loading conditions which affect these parameters. So specifically the tethering and the hyperkinetic effect has to be kept in mind. As you can see in the right side images, you can see the tethering effect wherein it is very important for a novice. So when a person is starting to do echo, it's very difficult for them to categorically tell what is the wall motion abnormality. So the most common cause of regional wall motion abnormality is coronary artery disease. So we need to know the cardiac anatomy for anybody to understand what is the regional wall motion abnormality. We need to know the ischemic cascade, wherein the visible wall motion abnormality is picked up much earlier than the ECG changes or even the symptoms. LV segmentation plays a very important role in understanding the abnormalities, and then we need to thoroughly know this LV segmentation because a lot of our interpretation depends on these. So we have 6 basal segments, 6 mid segments, the 4 apical segments and the apical cap, which is very important for us to know the segmentation. And obviously the arterial distribution and then which artery is affected, it depends on, we need to understand this so that we can interpret it properly. So how do we assess the regional wall motion abnormality? So whenever we are wanting to assess the wall motion abnormality, it's very important we look at various views of the echocardiogram and not rely only on 1 or 2 views. So we look at as many views as much as possible, and then only you have to come to a conclusion on the wall motion abnormality. So the ventricular segments are analyzed based on the following methods. The first one is the qualitative method, wherein we look at the wall motion and the wall thickening. This is the age-old method. It's the eyeball assessment, which we all do. But then I would be very careful in telling that this is not useful for the novice. So when we are starting to learn to do echo, we should not rely on the eyeball assessment, which comes by experience. And here what we look at is whether it's normal, hypokinetic, akinetic or dyskinetic, and also look at the presence of scar or aneurysm. The second method is the semi-quantitative method. It's just little more than the qualitative method, wherein we give a score to all the segments which are affected, and then we calculate and give a score index. The quantitative methods are very important because it gives a number, and there are various methods: fractional shortening or radial shortening, the fractional cavity area change, and then the various tissue Doppler methods, that is which includes even the strain and strain rate imaging. So before we proceed to evaluating, we should know the grading of regional wall motion. It's very important. Here we look at the LV wall thickening in systole. If it is more than 35 to 40%, we label it as normal. If the thickening is between 10 to 30%, it is hypokinetic, and we give a score of 2. If it is less than 10% thickening or no inward movement seen, then that segment is akinetic, and we give a score of 3. If it is dyskinetic, if it moves outward during systole, and a score of 4 is given. And if it is bulging outwards during systole and diastole, then it is an aneurysm and the score will be 5. So eyeball assessment is the age-old and very routinely practiced method, wherein we can look at whether the normal kinesia is there or whether it's hypokinetic, which you can see in the middle video. The apical segment is hypokinetic, and in the right side image you can see that it is akinetic. But then here the word of caution is, for a novice it's very difficult. If I show the right side image to a person who is not doing routine echo or is just started to do, he may give it as normal. So the eyeball assessment has to be done very carefully, and it comes with experience, and it's not to be followed by a novice. And also we look at presence of scar or aneurysm. Again, this is very important, and it comes with experience. So again, if a person is starting to do echo, it is definitely not advisable to go on eyeball assessment, but definitely it plays a very, very important role where we can define the anatomy. So going one step further is the semi-qualitative method, wherein we use the same score, but then we add, we give a sum to the wall motion scores of each segment and divide it by the number of segments which are observed, and we get a score index, which is little more qualitatively we can improve the sensitivity. The next method is the quantitative method. There is a fractional shortening or the radial shortening. Here it is calculated by measuring the percentage change in the diameter of the LV during systole using the formula LV end diastolic diameter minus the L systolic diameter divided by the end diastolic diameter. And if any value is more than 28%, we can consider it to be normal. So it can be done in various views. It can be done in either anterior-posterior axis, in the anterior-inferior axis, and the septolateral axis. The fractional cavity area change, again we are tracing the endocardial border in the end diastole and the end systole, and by using the formula we can have a value, and any value more than 35% is considered normal. So this fractional area change, again, it's very important because we can calculate the EF based on the value we get. The next method is the velocity imaging, that is a myocardial displacement. Here it gives some sort of quantitative data wherein we can give a number to the systolic motion of the annulus, but then again it is not very, very specific, and it is angle dependent, so it's not very useful for regional assessment. But then the same principle can be used for the strain imaging, wherein the tissue deformation can be measured and the change in the dimension or the length normalized to the initial length of the region of interest gives us the strain. Here you can see in this example the myocardial segment is seen, and then if it contracts, the strain is given a minus value. If it expands or relaxes, it's given a positive value. And when it is calculated against time, it gives the strain rate. So myocardial mechanics is important for us to understand the wall motion abnormality. So because the fiber direction changes from the right helix to the left helix, from the endocardium, subendocardium to the subepicardium, and then preferentially the predominantly the circumferential fibers are present in the mid wall. So the longitudinal mechanics, there are three mechanics which we need to know. The longitudinal motion, wherein the movement of the LV from the base to the apex is measured. The circumferential mechanics, wherein the during diastole and systole, the circumferential strain can be measured, and then the radial strain also can be looked at. So indirectly, radial strain we do it day in and out by doing the M mode across the LV. So rotation and twist mechanics, as a result of these, the clockwise and the anti-clockwise rotation of the basal and the apical segments gives us the twist mechanics. And then overall net benefit is the ejection fraction which we see. So the speckle tracking, here the principle is very, very simple. The myocardial speckles are detected by the ultrasound images, and the velocity is estimated as a shift of each object divided by time between the successive frames. So the 2D speckle tracking image acquisition is very, very important for us to understand, because the goal is to go from the subjective expert evaluation to a quick quantitative information, which will be easier and reduces the inter-observer variability. So how do we convert this into a daily practical clinical application? So first thing is to do a good machine setup. We should have high frame rates between 40 to 80 frames per second. Optimize the image by looking at the focus, adjusting the focus position, sector depth, sector width, avoiding artifacts, avoiding foreshortening, and obviously we need to have ECG gated recording. So these are the four basic images which we need to capture: the apical long axis, the apical 2-chamber, 4-chamber, and then the short axis at the papillary muscle level. And it's very easy. Within now with the automated machines, it's very, very easy. Within 2 to 3 minutes, we get these images, and then we can calculate the strain, which gives us the global strain and also the regional strain of each segment. It gives very, very neatly, and then it can be useful in for improving our inter-observer variability. And the graphs are given, and the eyeball, the bullseye plot also is there, which is very, very easy for us to read and communicate to the piece. So these are a few of the abnormal examples wherein you can see strain imaging. It will give specific characteristics, specific numbers which we can follow up the patients and then see how we can improve our diagnosis. This is another example wherein you can see the inferior wall is hypokinetic. So I'll move on to, so we had done a study way back involving around 50 patients of acute myocardial infarction, wherein we looked at the speckle tracking echocardiography to assess the global and the regional left ventricular function. What we found was assessment of regional myocardial function by speckle tracking echo, particularly the GLS, can be useful in ACS patients who are undergoing PCI in predicting the short-term recovery of the affected segment. And speckle tracking echocardiography can be used independent of the conventional markers to assess the regional and the global LV function. So, having said this, there are some limitations to the regional wall motion abnormality assessment because it is image quality dependent. Endocardial border definition has to be good. Angulation of the transducer during acquisition of short axis views is particularly important. Here in the image, you can see that instead of angulation, we need to move the probe little bit, slide the probe so that we get the proper short axis. And always we need to keep in view of the translational and the rotational movements of the heart during cardiac cycle. Having said that, also we should be aware of the non-ischemic causes of wall motion abnormality, be it conduction system abnormalities like left bundle branch block or ventricular pacing or premature ventricular contractions or abnormal septal motions due to RV volume overload or pericardial constrictions need to be kept in mind, and the other causes like post-cardiac surgery or posterior compression or etc. etc. So the limitations of wall motion abnormalities in up to 20% of the resting studies, the endocardial border definition is suboptimal, which is defined as the inability to visualize at least two myocardial segments of the LV. However, the advent of tissue harmonic imaging has significantly improved the endocardial definition compared to the fundamental imaging. But mind you, 5 to 10% of the studies employing tissue harmonic imaging are still suboptimal. And tethering affects the endocardial excursion and wall thickening. This needs to be kept in mind whenever we are assessing the wall motion. So various methods to improve the wall motion is very simple. You need to have the proper pro selection, have a good image resolution by adjusting the imaging frequency, the beam width, scan line density, improve the temporal resolution, and then utilize the tissue harmonic imaging. So, but nowadays all of us use tissue harmonic imaging, but then we need to be aware of the differences between fundamental imaging and the tissue harmonic imaging. So we need to optimize the 2D image. There are various methods. We adjust the gain, focus, depth, the dynamic range, use zoom modality, and adjust the sector width. Look at the imaging frequency and try to improve your imaging by improving the frame rate. And you can always use different color maps of the grayscale, which will suit to your eyes and improve the edge enhancement. So if all these things are not helping, then we have the contrast echocardiography. It is important because echocardiography per se has limitations due to poor acoustic windows in some patients, and some patients who are at risk and also have suboptimal imaging. We can use contrast echo which can be given intravenously, and the delineation of the endocardial border is very, very good. It also is helpful in improving our diagnostic confidence and reproducibility. Here we use the LV opacification method by using the heavy gases. The most common is the sulfur hexafluoride microbubble, which is almost less than the size of the RBC, and it easily passes through the pulmonary circulation and comes over to the LV side. So many studies have shown an incremental value of using contrast agents to improve the image quality, the percentage of wall segments visualized, the confidence of interpretation of resting and stressed echocardiography images. So these are the few of the examples which are there in this left side image. You can see without the contrast, it's very difficult to comment on the apical wall motion. However, with contrast, the same patient, you can see that there is a dyskinetic segment and also a LV apical thrombus. Another example wherein the presence of LV aneurysm, you need to rule out any LV thrombus. You can always use the contrast modality, and also it improves the endocardial border definition. So just few more slides on stress echocardiography. Dobutamine or stress echo is very useful. Due to this cost effectiveness, stress echo is best suited for the Indian scenario for diagnosis, prognosis and therapeutic decision making in coronary artery disease. However, it is underutilized in India. But I'm proud that Indian Academy of Echocardiography has published its guidelines on this, and I would recommend all of you to go through this document, very well written, and all the details of my next slides are taken from that article. Stress echocardiography relies on recognition of wall motion abnormality induced by regional mismatch between the myocardial oxygen demand and myocardial blood flow. And we can use stressors like exercise or pharmacological by dobutamine. So how to perform? It's very easy. You record the 2D baseline, 2D and Doppler echocardiographic studies, and then either use exercise or pharmacological method of stress. Exercise is preferred because it is physiological, it allows symptom correlation and permits assessment of functional capacity. We can use either treadmill exercise, supine bicycle ergometry, or hand grip like raising or squatting. But we don't usually follow this. These are the methods or the steps which we use. I'll not go into the details. Endpoints, obviously we need to look at all these endpoints. The most important is look for the presence of new wall motion abnormality. Pharmacological stress testing is required for patients who cannot exercise or when assessment of myocardial viability is the main objective. Here, most commonly we use dobutamine. With contrast, without contrast, there are some guidelines on protocols to follow. We can always go through this in the document. Indications, again, to stop, the thing is, we look at all these parameters, ECG changes and the blood pressure, and then obviously we need to look at the presence of new wall motion abnormality. Interpretation of stress echo, the qualitative visual assessment of wall motion thickening and the motion during rest, stress and following stress is the basic method for interpretation. This requires good image quality acquisition, systematic approach for reading, and considerable operator experience is required. Recommended method is we should use the digital cord screen format. Routine use of harmonic imaging is recommended. More frequent use of contrast and use of strain imaging in special circumstances is recommended. Steps for comprehensive interpretation, I'll not go into the details, but then we need to go step by step. It's all given in the guideline document. I would recommend to go through it because of paucity of time. I will not go through the details. And this is a very good table which is given, which will help us in interpreting the response to the stress echocardiographic analysis. So this is one of the examples wherein the cord screen format is used, and we compare the various views, the 4-chamber, the 3-chamber, 2-chamber, and then the short axis, and then we can go step by step and analyze and give our interpretation of the wall motion. And contrast study during dobutamine is recommended, and it gives us a very high incremental value in reporting. So to summarize my talk, the methods to improve detection of wall motion abnormality in routine clinical practice, the basic is to have a good knowledge of the ischemic heart disease, which is essential to evaluate the ischemic regional wall motion abnormality. Be aware of the non-ischemic causes of wall motion abnormality. Appropriate port selection and optimization of 2D image is crucial in reading the echo images. Use of harmonic imaging is very good. Use of LV contrast opacification improves the endocardial border definition. Semi-quantitative and quantitative analysis of wall motion abnormality is recommended. Strain imaging wherever possible, use it. And stress echo will definitely guide us in detecting new wall motion abnormality. So I'll end here. Thank you.